do you have any apologies?
Yes, Chair, I've had apologies from Nick Derman, Martha Early, and I think Nicola Airy as well.
Yeah.
Although I think Nicola had I don't know if anyone else can give her update later.
Yeah, I know she wasn't at Place Committee yesterday, and
Okay.
she had some reasons not to be there. I've also received an apology from Jerry Webb, who is the other councillor who attends this meeting.
No problems, noted.
Okay, thank you. And do we have any declarations of interest? None? Fantastic. Okay, and are there any urgent items of business?
No, Chair, I'm notified. Thank you.
Okay, brilliant. All right, then if we could just have a look at the minutes from the previous meeting. I had a look and I didn't see anything that looked inaccurate. Anyone got any feedback on the factual accuracy of the minutes from the meeting? Okay. And then with regards to matters arising, was there any feedback on any of the matters arising? Sorry, I'm just having a quick look myself. I don't think I had any either. Okay, all right, so no hands up for that. I can't see anything. I've just had a quick look, and I'd had a look before and didn't write any notes. Okay, so then on to the next agenda item, which is do we have any public questions?
No, Chair, none have been submitted this time.
Okay, all right, fantastic. All right then. Well, we're rattling along. We're 6 minutes early, but I think that's good because the dementia needs assessment is a massive document, and I've spent all morning reading it. And I think there's a lot to discuss here. So I'll hand over to you, Charlotte. Thank you very much.
Thank you, Chair. Good to see everybody. For those of you who I haven't met, I'm Charlotte Pavitt. I'm Director of Public Health at Bratton Forest Council, and we'll be presenting the dementia needs assessment that the team have done. I can take no credit for this. So I'm just going to share my screen. Please bear with. Okay.
Sorry, Charlotte, I've just realised it's really bad feedback.
Yeah. No, do come
while
in.
While you're doing that, is it worth us doing some introductions? Because I've just realised there are a few extra people on this call who might not know who the other people are. Let me get up gallery view, and if I just sort of say your name, and if you could just say who you are and what your role is, that would be great. So I'm just doing it as I see it on the screen. So Lizzie, start with you, please.
Yes, hello everyone. I'm Lizzie Rich. I'm the clerk to the Health and Wellbeing Board.
Thank you, Charlotte.
Hello all, I'm Charlotte Pavitt, Director of Public Health at Bratton Forest Council.
Thank you very much. Susan?
Hi, I'm Sue Halliwell. I'm Chief Exec of Bratton Forest Council.
Thank you, Andrew.
Hi, Andrew Hunter, Exec Director of Place at Bratton Forest Council.
Fantastic. Claire?
Hi everyone, Claire Shropshall, Health Watch East Berkshire Manager. You mentioned apologies for Nick Derman. Just to say I'm here representing Health Watch Bracknell, and either myself or Nick will be at these meetings. We'll rotate, we won't come together.
Fantastic, thank you. Grania?
Grania Siggins, Executive Director for People Services in Bracknell Forest Council.
Brilliant, thank you. Phil?
Good afternoon, everyone. So, Philip Bell, I'm the CEO for Involved Community Services at Local Council for Voluntary Services.
Brilliant, thank you. That's Marcus. That's coming up, Marku. I think it's Marcus, isn't it?
Yes, it's me, Megan. Hi, Marcus Warnes from the LJ here for an agenda item later on the agenda.
Brilliant, thank you. Jonathan?
Jonathan Picking. I'm the business manager at the Bracknell Forest Safeguarding Board.
Fantastic. Fidelma?
Jonathan Lee Berkshire Curses.
All right, nice to meet you. Okay, and then Mark?
Hi, Mark Young, Director of Capital Estates and Facilities for Frimley ICB.
All right, so you're speaking at the very end. Thank you. Nice to meet you. Jonathan?
Jonathan McShane. So along with Marcus, I'm one of the LGA associates.
Brilliant. Thank you so much. And then Sita.
Hi everyone, I'm Sita Reddy. I'm a consultant in public health. Sorry.
Sorry, I've got terrible feedback there. Were you saying that you're Sita from primary care?
Sorry, it's Sita Reddy from public health.
Okay, thank you. Thanks. All right. Right, back to you, Charlotte, for the dementia news strategy, if that's okay.
Thanks both. Just to say, so can you hear me? Yeah. Sorry, Sita is a consultant in public health. She'll be overseeing the review of the health and wellbeing strategy. Apologies, we're in the same room and having some technical hitches with feedback on 2 screens. I'm not able to share the to share a specific window, so I'm going to have to share my screen. So just bear with me while it's a little clunky in getting the presentation up.
Would it help if
if everyone's able to see this, hopefully, please let me know if it's not showed in full screen mode.
It's showing
I can't
now.
see anyone, so great, perfect. Okay, thanks all. So we have undertaken the dementia needs assessment. The work for this piece of work has originated under the health and care plan. There was a key priority and an action within that health and care plan to develop the integrated joint dementia strategy that will dovetail onto the back of the previous dementia strategy, which ceased in 2019. And therefore the needs assessment had an aim to look at population needs in relation to dementia, but also includes those caring for those living with dementia, look at the support and the services that sit around the individual, including preventative services and support, and then to identify the gaps and make some clear recommendations. These slides, there is a lot of information. There is a lot of information in the strategy. I haven't got the time today to go through that, so I am taking it as read and we'll be flitting through the slides. But do please interrupt and ask any questions at the end if there's anything that I haven't covered that you want to understand a little more. The needs assessment and these slides give a background to dementia. Just to say that the needs assessment covers all types of dementia and also considers late and early onset, so just in terms of its scope. In terms of the burden of dementia, it's not unique to Bracknell Forest. This is a significant public health issue nationally, and it's not just the issue with the current need, it's the growing need and the projected increase. And we can see from that second bold point that increase is projected to be nearly double, from 51 million in 2019 to nearly 100 million by 2030. So it's not just a significant issue now. We need to consider the risk and the demand and the need moving forward in our strategy development. The risk factors around dementia, there are a number of risk factors. We split those to both non-modifiable and modifiable. Aging is a key risk factor, and we all know that we have a growing aging population, hence the projection in demand moving forward. Gender, ethnicity, genetics, to greater and lesser extent, all play a factor in the risk of dementia. We can't change those, but we need to be aware of them, and we need to be aware of the inequalities that present as a result of these factors. What we do have control over, however, is what we deem these modifiable risk factors. And they're noted in this diagram right the way from early life in terms of level of education, through midlife, largely in terms of behavioural and certain other diseases. So listed here, we've got smoking, we've got hypertension, we've got obesity, alcohol use, diabetes, physical inactivity, and depression, as well as some of the others noted there. And then as you move into later life, social isolation, air pollution, and visual loss, but particularly the social isolation piece. Now, all of those we do have it within our gift and control to support, to reduce, and thus have an impact on that scarily increasing trajectory. Looking at the prevalence of dementia, we've got here the numbers both living with dementia in against the population aged over 65 and over, and then we've got the estimated the number of people living with dementia by age group as well. So we can see even year by year that slow increase coming up as a percentage of the population. So it's not only the population of 65 and overs that's growing, we're also seeing a higher percentage increase within that population. So it's a double whammy. And you can see here the proportion of those in 65 to 74 age group, 74 to 84, and over 85. And again, the numbers living over 85 are growing, along with the proportion of individuals living with the disease. We've also got insight into geographic spread and variation in the different types of demographics. We can see here the bullet points around females, age groups, ethnicity, and deprivation. So what those percentages show is the numbers that have been recorded as having dementia against the population profile for Bracknell Forest. So we've got a disproportionately higher number of females diagnosed with dementia, a higher number, a significantly higher proportion of those aged 80 to 89, which we would expect compared to that population as a whole. A higher proportion of white individuals compared to the proportion as a whole in Bracknell Forest, and again deprivation. I do have to say this is caveated because this is the recorded prevalence. So these are individuals with a diagnosis who's had it recorded in primary care. This may not be a true reflection of need. There may be some access playing into these disproportionately high numbers. And again, you can see the distribution across wards there too. The needs assessment considered the policy context and the backdrop. There is, as we would expect, given the significant public health risk nationally, a series of policy positions and guidance documents that focus and support the dementia agenda. The Challenge on Dementia 2020 is noted here, but also some of the more generic policy documents, the NHS 5-year forward view, and their specific guidance from NICE, as well as the NHS Well Pathway for Dementia, that's all considered in terms of setting out where we should be moving towards in the strategy. There's some further detail on that Dementia Well Pathway. The Dementia Well Pathway has 5 areas that it considers. preventing well, diagnosing well, supporting well, living well, and dying well. And therefore, that is how we have structured the findings of the needs assessment. So in terms of preventing well, I am going to whiz through these. I want time for conversation and not taking too much time on going through these step by step. The points to pull out are the points noted in bold. We have over 2/3 of our adult population living in Bracknell Forest are estimated to be overweight or obese. And as you can see from that top graph, the Bracknell Forest rates in blue line. We've got the southeast region rates in the orange line, and the national rate, well, English rate in the grey line. We've seen a significant hike. We've just discussed it in one of our public health meetings this morning. It's not known at this moment in time if that's the trajectory or what has caused that significant hike in Bracknell Forest away from the national and apologies. Oh, there's a problem with sharing my whole screen. That hike away from the national and regional averages. It may just be a blip because we have smaller numbers within our borough, and so there may be some data noise going on here, and it's not a true reflection of an increased spike. That said, regardless of the trajectory and where it's going with overweight and obesity, 2/3 of our population are overweight and obese, which will increase the risk factor for dementia moving forward. And so there's a significant piece of work to be done, and we'll come on to the what later, around reducing the rates of obesity and overweight in the borough. Smoking and physical inactivity are noted here. You'll see from all of these behavioural graphs that I present and some of the other graphs, there are spikes that occur from 2021, depending on when the data is shown. This is the fallout of COVID. So we saw spikes in prevalence of smoking from 21 as a result of the impact of service provision, and also the challenges that the pandemic that set for our local communities. Physical inactivity is noted, the blue line at the bottom. Again, a spike up in terms of inactivity in Bracknell Forest in pandemic. That has come down, which is positive, but it still looks to be rising. So physical inactivity is something that we can promote and that will reduce the risk of dementia, and as we can in terms of smoking cessation support available, and the wider tobacco control agenda to create healthy environments to reduce the likelihood of uptake of smoking and vaping. Depression is another risk factor that we can look to modify. We can see here the Bracknell Forest lines are in blue. We've got increasing trends in the percentage of adults, our GP patients with recorded depression. And so this is only those who have been to their GP and had it diagnosed. There will be potentially higher percentages of the total population living with depression. And the incidence of new depression diagnosis is also increasing. Then the second, as we move on from how we prevent dementia from occurring in the first place, the next step is diagnosing well, and timely, accurate diagnosis is key to ensure that the individuals have the support available to them in a timely way. We can see here that Bracknell Forest's graph at the top is in blue, the diagnosis rate for dementia compared to our Southeast region in green, the England average in black, and against the target, which is the red dotted line. So the target minimum national ambition is that at least 66.7% of people estimated with dementia will have a formal diagnosis. In Bracknell Forest, that was below that national ambition at 63.3%. So there's work to be done in terms of timely diagnosis as well. Also, in that diagnosing well element of the good practice, there's good practice around having annual GP care plan reviews, and here it compares how we're doing within each of our PCN areas at the top right graph, the percentage of our GP patients with dementia that have received a care plan review in the past 12 months. We can see that there is variation, albeit slight variation between our PCNs, but all three of them are lower than the Frimley average. Our health triangle PCN being significantly lower because those black lines of confidence intervals don't overlap, and also lower than the national average, which is in the blue. So 69% of our patients with dementia had their care plan reviewed in the last 12 months. So that's a third, just under a third, 30% who didn't. And we need, that's something that we do have control over and will be included in the recommendations. And we can see that whilst there was a huge drop off during the pandemic at the bottom graph, that has come back up more recently, but it has now leveled off. It hasn't continued to increase, so we need to look at improving that. Moving on to supporting well and ensuring that individuals have access to safe, high quality, both health and social care support for the individuals themselves who live with dementia, but also their carers. Focusing in on here with residential care, we can see that the residential care and nursing home capacity for people with dementia is significantly lower in Bracknell Forest compared to the South East and England. We know it's significantly lower. You can just about see the little lines of the confidence intervals, the black lines. If they don't cross over, then it's a true difference between local rates and the Southeast and England. And we also had a significantly lower percentage of beds suitable for people with dementia rated as good or outstanding by CQC. As we move on to living well and supporting people to live normally in safe and accepting communities, here we've got a measure of the percentage of adult social care users who have self-rated as having as much social contact as they would like. We can see it was a huge drop-off following the pandemic. It has increased back up towards our Southeast and England averages, but still only less than half of our adult social care users in Bracknell has reported as having as much social care as social contact, as they would like back in 2023-24. So again, as a modifiable risk factor, that social isolation, that's something that is within our gift to think about and support as a system. And then finally, dying well, people living with dementia, supporting them to with dignity in the place of their choosing. We have here just a description really of where individuals are dying with dementia. We can see the vast majority in 2023 in the bottom right graph do die within a care home. Only 14.3% at home and nearly a quarter in hospital. So again, thinking about how we facilitate choice in death. We've noted here, and it is captured within the report, over and above the statutory services that are supporting, so the community mental health team for older adults in partnership with Berkshire Healthcare NHS Foundation Trust, There's a whole host of wider support available that's noted on the next couple of slides, and also the structure that sits around that. We have had comments come back in, and further services have been captured and will be updated. So, and again, following the comments from the Health and Wellbeing Board, the health needs assessment will be amended and updated and then finally published. In addition to the support specifically focusing around dementia, it's also captured what support is available from a public health perspective and some of those modifiable risk factors. And here captures the NHS Health Check programme that is delivered within primary care, that's commissioned by Public Health. We can see that around just over a quarter, 26% of the eligible population, so those aged 40 to 74, were invited for an NHS health check. And there's a significant improvement programme that's currently underway to work with primary care to incentivise the NHS health check programme and to increase that. And in addition, not only the invitations, but then who's coming in and receiving the NHS health checks. It's a steady, slow declining line for England, and an overall declining trend in Bracknell Forest at the bottom graph around the uptake of those invited. So again, work is being done both within primary care and the communities on the importance of going for that check and understanding the risk factors and receiving the advice or treatment, whatever it may be, to improve overall health outcomes, but that will have an impact on the risk of dementia also. We've got Smoke Free Life Berkshire providing specialist support for stop smoking. We have a physical activity fit for all programme. We've got the Stepping Stones Recovery College for those aged adults aged over 18 for mental health and recovery from addiction. And we've also currently got a social prescribing service, both within public health, which is being reviewed currently, but a universal provision within primary care for supporting individuals and connecting individuals back into the community to reduce social isolation. So I'm just there will be specific recommendations that are picked up given some of the statistics that I've presented. That will all be captured within the strategy moving forward. But some of the strategic recommendations around thinking about the impact of the growing need around dementia moving forward. We need to factor in the planning and commissioning of services, not based on the need now, but based on where the need is going. There needs to be a significant focus on reducing the prevalence of the modifiable risk factors, and looking at the public health work programmes to offer universal and targeted interventions to reduce up to half, was the statistic, of diagnoses are preventable. So we could have a huge impact on a focus on those modifiable risk factors. Earlier diagnosis and support for people with dementia. We do need to get up to that national minimum ambition of 66.7%, so 2/3 diagnosis rate, and then increasing the support for people with social care. So looking at doing further surveys, stakeholder engagement, and focusing on that loneliness and social isolation, as well as the provision around the needs resulting from dementia for both the individuals and the carers as well. So the next steps, we are coming to the end of socialising the needs assessment. It's been to the Dementia Forum, it's been to the Place Committee, it's now here with the Health and Wellbeing Board. final comments will be incorporated after today, and that will be then published. And it's sat now with colleagues under the action of the Health and Care Plan to develop that detailed strategy and action plan, and the next steps in terms of implementation of those actions. I will stop sharing and pause there.
Charlotte, that was fantastic. You've got that feedback thing again. Sorry. I'm aware that we're already 2 minutes over time, and I've got quite a lot to say on this. I can see Gronia's got her hand up, Sue's got her hand up. Can we allow an extra 10 minutes? I know, so that's Marcus and Jonathan. If we'll just come into you guys a bit later, just so we can have enough time for a bit of discussion. So over to you, Gronia.
Yeah, no, it's wonderful to finally see the dementia needs assessment. In 2023, we identified collectively in the place committee that we needed a dementia strategy, and for which we needed a refresh of the dementia needs assessment. The information in the joint strategic needs assessment at that point was insufficient for us to do that, and we reached out to our public health colleagues to develop that for us. So really, in terms of next steps, we'll be utilising whatever comes out of the final needs assessment to then continue to use it to develop the broader elements of the dementia strategy. So it incorporates all aspects for us as a council and our health partners. It's going to need a whole range of things, including planning, living well with dementia, as Charlotte has mentioned, includes financial planning for the future. Increasingly, our population is the prevalence of dementia is very obvious in our aging population, and over a long period of time. So supporting people to manage well with dementia within the family and within a couple relationship is really important for all the reasons that we know, including that effective planning for people as they age, the importance of technology and assistive technology, importance of having the right housing at the right time. We do know, in addition to the decision on the care homes, for which we developed the provision within Heathlands, we do know that we haven't got sufficient extra care, for example, for that cohort of people for that period of the life where they could manage in extra care. So it's going to be utilised to develop a whole range of elements within the dementia strategy, which will be overseen by the health and care, by the place committee within the health and care plan and that update. We do expect, in the way that we are with all of our integrated strategies, to then that formally reported annually, go through its route of governance for sign off, formally reported annually through the Health and Wellbeing Board in terms of updates too. So just wanted to talk you through next steps, but we are mindful that we identified for it to be concluded by March 25, but we unfortunately didn't have the needs assessment in place, appropriate detailed one by that time, for a range of reasons. So hence why it's taken longer than we'd specified it to take in order to finally develop the strategy via the needs assessment. So just wanted to be clear about that, in terms of still a huge amount of work to do on it.
Okay, fantastic. Before Sue comes in, just really, because it's following up on what Gronia said, it almost looks to me like you need an extra category saying living well, aging well. And that's when you bring in those conversations, try and bring in those conversations early about aging generally, rather than just dementia. So thinking about moving to more suitable accommodation, doing your lasting power of attention. It's almost like we need a public health campaign there about how to age well and how to get yourself in a situation where you're not having these crises and emergencies. And it's something I feel quite strongly about, and I'm just wondering if we need to add that in as an extra step. So we're reaching people before, we're reaching people my age and, sort of from their 50s into their 60s, about how are you going to age? What safeguards are you going to put in now to help you age well and to help you live well in disability, whatever that might be. So anyway, right, I'll be quiet and I'll pass on to Sue. Thank you.
I'll beat that. That chimes really well. So yeah, very much agree with that. I think that's a great idea. I just Charlotte, first of all, well done in getting through such a huge richness of information and distilling it. I thought it was excellent. Thank you. It just led me to maybe a reflection and a question. One, that level of obesity in our place, given that we have so many open green spaces and we have fully accessible open spaces, they may well be utilised, but maybe there is something more that we need to do to understand that level of obesity and people who are overweight. I just had a question, and you may not be able to answer this, but you made a comment there around these are the known cases, and there will be an element of cases in the community that we're not aware of. Are there assumptions that we can make from other places, or any way of which we can identify what that quantum might look like? Given just reflecting on Councillor Wright's observation around how we communicate living well when you're older, and how we capture that, and whether there was an understanding as to why the take up of health checks have declined recently, if there was a trigger for that.
Yeah. So, have you got? Can you hear me? Sorry, we're having technical issues here where we've got feedback, but I can't switch it off. So just in response to the point on the data and the known diagnoses and actually what does that look like in reality, there is national and evidence base around that we can apply to a Bracknell Forest population. So that's absolutely within our gift. In terms of the second point, and so just remind me on that second point that you raised with the obesity agenda. Sorry, I haven't.
Sorry, trying to come off mute. No, I was just reflecting on the level of. I think if you go on mute, okay, then I think it stops the echo. I reflected on it wasn't really a question, it was just a reflection around that level and making that transition between the fact that we have got, and I think Councillor Wright put in the chat around active travel, we've got amazing cycle networks, we've got amazing green open spaces, yet we have this high level of overweight and obesity rates. So it's more of a kind of challenge to the place as to how we can address that sort of discrepancy.
Yeah, absolutely. And it was the point on health checks as well. So within the work programme within public health, the whole systems approach to healthy weight is something that is a priority for us. We are looking at weight management services, further investment, and the wider wraparound it's not support, it's that whole systems approach in terms of our environment and how that creates opportunities to maintain healthy weight and to reduce health and well-being. So there's absolutely a focus on that. There's also going to be an increased focus on NHS health checks. We haven't had the systems in place to collect who it is that's taking up health checks, why people aren't taking up health checks, and therefore to have that knowledge and insight to do something about it. That system has now been implemented and funded, and we have reviewed the contract of health checks with our primary care. So a lot of work has gone in over the last 12 to 18 months to tackle both and to improve the numbers of invites of health checks that are going out in the first place, but also the uptake. So we hope this is old data, and unfortunately those national data pieces are slow in coming forward, but we're seeing a much improved trajectory. So moving forward, absolutely the case. And then I think, Councillor Wright, your earlier point on generally aging well, it's really timely. All this insight is always timely, but particularly with the refresh of the health and wellbeing strategy. And I would be hugely surprised if aging of some description, however we want to term it, doesn't feature in the health and wellbeing strategy moving forward, given our population and where it's moving to. So I think you're right in picking it out in relation to dementia, but actually we could have a focus as a health and wellbeing board more generally on our ageing population moving forward under that strategy.
Completely. All right, Andrew, over to you, and then I think we'll have to move on to the next subject. Okay, thank you.
Thanks. Just a couple of points from me. I think it's a really excellent piece of work, and I don't think we need to wait for the strategy to be implementing some of the things that we've talked about, and we shouldn't be. As a system, I think there's something about how we get some of those messages out in all places. So through our primary care, through our voluntary sector, through our council work, through social care. So some thought maybe on the comms of how we get some of the data that's within here that tells us some very clear, easy wins that people could do to keep themselves out of the dementia risk zone, if we can call it that. And then my other point is a bit more of a technical one, is that within the document, it would be quite helpful, I think, perhaps once we get to the strategy, to understand the barriers for those who are self-funders and those who are coming through the social care side of things, and whether there's a difference in the uptake of things like the health and care, the health checks and things like that. I suspect that there may be some self-funders out there who are just getting on with it and not really realizing what might be out there. So just observations, but really helpful, and I think leads us in really nicely to the health and wellbeing strategy.
Thank you. Charlotte, anything else to say on that, or shall we move on to the next agenda item? Okay, and good point, Andrew, about the difference between private and social. I've made a note of that as well. Fantastic. So if we now move on to our next agenda item, which is welcome to, well, Charlotte, do you want to introduce and talk to us? Yeah,
of course, yeah. So and Lizzie, if it's possible to share the slides, that would be helpful. I think that's probably better than I doing it here with this connection. So as the board is aware, we've had the support of the Local Government Association, the LGA, and Marcus and Jonathan are on the call to do a piece of reflection on the form and function of the board. The purpose of the board is really timely and runs really nicely in parallel to the refresh of the health and wellbeing strategy. A series of, I'm not going to deliver their presentation for them. I'll introduce Marcus and Jonathan to come in, but this is just by means of an update to the board to keep you briefed and to feedback with where we currently are, and to explain where we're going to be taking this piece of work next. So I'll hand over to Marcus and or Jonathan, and then Councillor Wright, you'll come in at the end just to talk through the next steps and where this is going further.
Thanks, Charlotte. Hi again, everyone. I think some of you were at the meeting a few months ago when I said a few words around what we've been actually invited in to do. So if I just briefly introduce myself, and Jonathan could do likewise, then there's a few slides that we can run through, which just give you a flavour of the review that we carried out over the last couple of months. So very briefly, Marcus Warnes. Up until the end of December 2022, I was a chief exec in the NHS. Retired from the NHS, and since then I've been doing some consultancy work, the vast majority of which has been the Local Government Association, supporting health and wellbeing development, place development, governance reviews, a whole raft of things. And I think, as I said last time, having worked in Stoke for quite a long time, getting out and about and seeing how the rest of the country do things has been fascinating. And I think we were particularly keen to do this piece of work because I think it's fair to say that Frimley ICS, from an NHS perspective, has always been the poster child for integration and all things good around working together. So it's been good to come and speak with you and see what you've been up to firsthand. So, Jonathan, do you want to just say a few words and then I'll kick off with the slides?
Sure. So I'm Jonathan McShane, and so like Marcus, I go around the country advising health and wellbeing boards for part of my week. The rest of the time I do some work in the North East London ICS, and my background is as an elected member and cabinet member for health and social care in Hackney in East London for many years. And then we've really enjoyed the work today and are looking forward to continuing this work over the next couple of months. Thank you.
Thanks, Jonathan. So can we have the next slide, please? Thank you. Just to say up front, as I said last time, this wasn't an inspection. It's not a CQC visit. There's no ratings or anything like that. It was something that the LJ were invited in to do to support the Health and Wellbeing Board in its development. And I think it's fair to say it's probably a pretty opportune time to have done this. We were asked to look at a number of things, primarily the role and purpose of the Health and Wellbeing Board, something around its role specifically as a strategic partnership, whether it's making a difference and adding value, and also ways of working as a strategic partnership. A huge thank you for giving up your time for this review. We did ask for an hour with all the Health and Wellbeing Board members and one or two other significant people. And I think we spoke to pretty much everyone that you asked us to, including Sam Barrows, the Chief Executive of the ICB, who was incredibly helpful in his reflections on the wider system context within which the Health and Wellbeing Board is operating. We did agree to give some additional feedback here. I think the couple of slides we've got doesn't do justice to the huge amount of information that you shared with us, and we will be going through that in a much more detail. Probably less about what we heard, more about what we can help you to do with it at the workshop in November. Next one, please, Lizzie. So very much a summary. The report, there's a lot more in it. There's a lot more detail in it, but we have just pulled some key things out which we felt it might be helpful to reflect back to you at this meeting. And I'm conscious of time, so I will whiz through this fairly quickly. I think it's fair to say for most people, whilst they may well have understood what the statutory guidance says the Health and Wellbeing Board should be, in reality, they were a bit less clear. And I think this is something we find all over the country, particularly following the inception of integrated care systems. I think the role and the purpose of the board, Health and Wellbeing Boards, has become a little bit fuzzy over the passage of time. We also heard that it's probably more of a meeting. People attend, receive reports and presentations rather than a strategic partnership. Really good time to be doing this, given that you've got the health and wellbeing strategy refresh. I think we heard from an awful lot of people that there's a lot in the current strategy, lots of priorities, lots of areas of focus, and people felt it would be good to maybe narrow down on one or two things that perhaps could provide a medium-term focus for the board over the next year or two. Focus on one or two things and do them really well, rather than try and do lots and lots of stuff, perhaps not so well. Relationships are really good. We probably expected nothing less, and I think people generally felt that they could have difficult conversations without falling out, and those relationships, based on a long history of integration, I think put the board in really good stead in terms of finding its place within the system going forward. There were a lot of concerns. I think pretty much everyone we spoke to were concerned about the potential impact of ongoing reorganisation on the NHS side, but also from a local government perspective. And I think it's fair to say, correct me if I'm wrong, but I think Frimley ICS, for instance, has been sort of sent in three different directions in terms of, I think East Berkshire going off to Bob ICS, some of it going to Surrey, some of it going to Hampshire. So real concerns around what that meant for relationships and how you work together collectively. Whilst we were asked to look at the relationship of the board with place, I think most people felt, given that's going to change fairly soon, it's probably better to be focusing on how can the Health and Wellbeing Board help to shape the future shape of place. And we heard an awful lot about that, which it probably would be helpful to maybe have give some time to at the workshop in November, when things maybe will have become a bit clearer in terms of what the future looks like. I think people felt it was probably hard to know whether the Health and Wellbeing Board was making a difference. And we got a few examples of where people felt it had, but probably more regular updates on performance against key outcomes, etc. I think people felt would be helpful. There was a general sense that this is the place where we actually do inequalities, where we have some of the conversations we perhaps don't have elsewhere. But I think people felt there was a real added value having a Health and Wellbeing Board that brought those senior leaders together to have those conversations, to focus on the really important stuff to your population. I think the previous example was previous item was a good example of that. Probably not enough happening between meetings. I think we did ask people what happens in between meetings, and probably not as much as could happen in between meetings. You meet 4 times a year for a couple of hours. That's maybe 8 hours a year you're together as a health and wellbeing board. So there was something about, well, what happens in between meetings to drive the delivery of the health and wellbeing strategy. And there was a real enthusiasm amongst the people we spoke to contribute more. I think people were perhaps not clear how they could contribute more, but wanting to help to shape forward plans, business plans, agendas going forward. There's a real appetite to do that. Next slide, please, Lizzie. So the recommendations are very much based upon what we know works elsewhere. I mean, Jonathan, I've been doing this for a couple of years, Jonathan longer than me, but the LJ have got huge teams of people that have been working with health and wellbeing boards for 12, 13 years since their reception. So there's a huge amount of data around what good looks like. So I think probably the priority we would suggest is probably going to be looking at the role of the Health and Wellbeing Board, particularly within an evolving system, but also the role of individual board members. You know, what's it's not just to come to a meeting every quarter, but what is it? What are the expectations of board members? When they at the meetings and also outside of meetings. We would really encourage you to reach consensus on 1 or 2 things that you can really focus in on. It's not for us to tell you what those things are, but you've got huge amounts of data that potentially would enable you to reach consensus around what your year 1, 2, year 3 focus could be within the health and wellbeing strategy. I've said a bit about where the board fits at place. Probably that's something to do in the near future, maybe not something to focus too much on in November until we know what that looks like. Expectations of partners both at and outside meetings was something that came up again and again. What am I here for? What are the expectations of me as a board member? And also something around sort of briefing pre and post meetings people felt would be helpful, particularly outside the council. Engaging more effectively with all stakeholders, good engagement between board members and partners around the table. There's an awful lot of organisations that could be impacted by and could help to influence and inform the Health and Wellbeing Board that people generally felt perhaps weren't being as engaged with as effectively as they could be. People talked a lot about neighbourhoods, communities, and also the third sector. I think there's an expectation that someone is invited onto the board and they're expected to get it and to get on with it. I think we heard from a lot of people they would be appreciation and support in how they actually develop and deliver their role. Partnership working, system working, strategic partnerships generally are really, really difficult. It's hard. And the board as a whole and the individuals on the board, I think we generally heard would probably benefit from some ongoing support and development. I think people felt they'd like inclusive conversations around how each meeting is used. A few people said they weren't sure how agendas were set and would probably like some involvement and engagement in that, not just the next meeting, but the forward plan of meetings, and also how that aligns to the strategy, which people felt was should be the key focus of the Health and Wellbeing Board. Something also around operating strategic partnership and ensuring the papers reflected that. Most health and wellbeing boards tend to have most of their agendas filled with the statutory stuff, the things they have to do, and probably freeing up space on the agenda to focus on the 1 or 2 really important things that you could and should be focusing on. I think the dementia one, the item beforehand, was a good example. Something really important to you. The evidence tells us it's important. We need to do something about it, and clearly you've had I think a helpful presentation and discussion. Maybe more of that going forward. People felt would be helpful. Really get stuck into a big meaty issue in the meetings. And there's also something around measuring progress. This isn't about an industry of performance management. There's huge amounts of data out there. There's lots of performance reports, etc., that people can read and look at. But what are the 1 or 2 key things that metrics that you need to turn the dial on that will tell you as a board you are having impact, that you are being successful in improving outcomes for your population? One side of A4 dashboard people felt would be quite helpful to refer to from meeting to meeting, and when you carry out your annual reviews, to see what kind of an impact you've had over the last year or 2. So I think I'm handing over now to the chair, I think, Charlotte. That's right, isn't it, for the next 2 slides? Yeah, thank you.
Is that me now?
It's you, Megan, I think, yeah.
Okay. All right. So I'm also slightly aware of time. We're slightly behind, but the whole reason we commissioned the LGA to help us was to we're about to do our health and wellbeing strategy, and we wanted this kind of input now. We wanted to make sure that everyone was engaged in the design of how the Health and Wellbeing Board is working, and is it delivering for the council, is it delivering for our residents? And so the next steps in this are that we're going to have a workshop. What's that? Sorry, Charlotte, what's the provider identified? What was that about? Is that about someone? Is that about?
Yeah. Excuse me. This is just sorry.
Oh, sorry. Well, we'll just skip that. Charlotte did tell me, and I've forgotten. But we're having a session in November. When Charlotte comes back, she can remind me what the October thing is. And then at the same time, so that will be a face-to-face workshop just in the last week of November, just before our next Health and Wellbeing Board. And then at the same time, in the background, there's people working on the Joint Strategic Needs Strategy, a Joint Strategic Needs Assessment, and then by summer next year, we'll have pulled all that together to release our new Health and Wellbeing Strategy. Right, Charlotte, have you got your breath back?
Sorry, that was an unfortunate coughing fit. Yes, so it's just the opportunity for us to align what Jonathan and Marcus have worked through today with, actually, we've got the new strategy that's about to be refreshed. What's going to be driving and underpinning all of that is the Joint Strategic Needs Assessment. And it's just to update the board that the decision's been made to commission that out from public health to bring in expertise to both look to undertake the co-design piece for both elements, really, and also then the development and the publication of both of those. And I've just noted the timescale here. So it's just to assure the board that there's an opportunity here for us to align these two elements of our statutory responsibilities with actually the form and function work of the LGA review as well. And then the final slide, Councillor Wright, that goes on to what you were just referring to in terms of that deep workshop and what's happening.
So this is the one on the 24th of November, and we'll get all the members of the Health and Wellbeing Board together and actually have time to discuss, what the role is, planning for impact. And as Marcus said, our discussion we had earlier, having more discussions like that about, what are our priorities for the borough, and then and how we're going to work together as a partnership. And I really like Marcus's points about the working in between meetings as well and following up. Okay, Andrew, I can see you've got your hand up.
Yeah, just a very quick one. Is the session in November going to be in person?
Yeah, it's on. I think that's on Monday. Oh, sorry, and then we actually have the Health and Wellbeing Board meeting on the Thursday. Yep. So that's a session on the Monday. Okay. Thank you. All right. Have we got any further questions, or Charlotte, is there anything else you wanted to add?
Nothing further unless anybody's got any questions.
Okay, fantastic. All right. Well, thank you so much, Marcus and Jonathan. Thank you for all your work that you've done on this, and we've all had our chats with you, haven't we? So yeah, really appreciated, and looking forward to the next steps. Thank you.
See you soon. Thank you.
Thanks a lot. Thank you. And then if we could just move on to the next agenda item. Sorry, we're running 10 minutes late, but we're actually scheduled to finish a bit early, so we'll probably end up finishing on time. It's over to Abby, who's going to be talking to us, giving us an update on the community strategy. Over to you, Abby. Thank you.
Thank you, and good afternoon all. Lizzie, would you mind sharing the slides, please? That would be great. So the purpose of the agenda item this afternoon is to provide the board with an update on the development of the community strategy, and also seek the board's input to a couple of questions which are included at the end of the slides, principally focused around how we can align the development of the community strategy with the development of the health and wellbeing strategy. But just briefly, and I won't talk in detail through each slide because they've been circulated in advance. The Stronger Together strategy is being produced by the community for the community, focused on how we can develop strong, connected and cohesive communities across Bracknell Forest. Thank you, Lizzie. Next slide. Sorry, and next slide again. Thank you. I'm very much focused on ensuring that all residents across the borough feel a strong sense of belonging, that they can actively get involved and take part in addressing issues in their local community and get involved in community life, as well as ensuring strong relationships within and between communities across the borough, and therefore ensuring that through those sort of active, engaged and cohesive communities, there's a real focus around prevention and early intervention. Next slide, please, Lizzie. So in terms of the strategy itself, its development is being overseen by the communities partnership, and I'm pleased we've got Phil on the call this afternoon, who is leading the delivery group. And if we could go on to the next slide, Lizzie. There are just over 18 community organisations actively involved in the development of the strategy, and are co-producing the 10-year vision and aims and objectives for the strategy. Next slide, please, Lizzie. So in terms of where we are with the strategy development at the moment, over the summer we've been in the understand phase, engaging with residents, community groups and partners right across Bracknell Forest to understand their views on what's strong and working well about communities within the borough, and to get their direct input into the strategy's vision and its objectives. If I just provide a bit of an update about how that engagement work has gone. Thanks, Lizzie. Next slide. So the engagement has taken place across a number of community events, but partners have also been out talking to people where they go in some high footfall locations. So there's been a large number of pop-up engagement events, and also some workshops and focus groups with particular parts of the community, including faith and belief organisations and disability groups and community organisations. There's also been some great engagement from school children with engagement with a secondary school and primary school, as well as all of that face-to-face engagement work being sort of underpinned by an online survey, which has been promoted very widely and all residents could take part in. Thank you. Next slide, Lizzie. So in terms of the level of engagement, I think we've now heard from, and I think the figure has been updated since this slide was produced, just over 2,200 residents who've either fed back directly through the online survey or through the face-to-face engagement events. And we're now at the end of the understand phase engagement programme and starting to move into focusing on the analysis of what communities and residents have told us, and starting work on bringing together the strategy. So thanks. Next slide, please. So in terms of the next steps, the focus now for the partnership delivery group is on the drafting of the strategy and the group met earlier this week to start to co-design the strategy's vision and its aims and objectives, and the action planning work will continue throughout September and October. It's planned that there'll be a 6-week public consultation on the draft strategy, kicking off from the 5th of November, and then following that, we'll want to listen to the feedback from residents there, review the strategy again, make any changes based on that feedback, and then between January and March, the strategy will be finalised and presented to partner organisations for their endorsement of the strategy, so that we can be delivering year one of the strategy from April. But we'll also be looking at, and the delivery group have had a conversation about, identifying quick wins and things that we can immediately start to work on through autumn and winter. So to finish, just a couple of questions to reflect on with the board. Regularly have sort of meet with Charlotte, and we've been discussing the plans for the development of the new health and wellbeing strategy. So be really interested to hear thoughts and views on how we can ensure strategic alignment between the community's strategy and the health and wellbeing strategy, and how the one can sort of underpin the other. And also any reflections on the kind of leadership and organisational development that's required to help enable community participation and empowerment and collaboration. And finally, any thoughts on some of those key actions that we need to be taking over the next sort of 1 to 3 years in terms of building strong, connected and cohesive communities. But we've shared at the bottom of the slide there an email address, appreciating that you might want to reflect on those questions and send through some feedback at a later date, given we've got limited time this afternoon. Thank you very much, Chair.
Thank you, Abby. Actually, in all honesty, I wouldn't mind a few minutes of discussion, because I think they're really important questions, especially as we are looking at a health and wellbeing strategy. And I mean, the one that immediately springs to mind is the dementia thing and social isolation. So I can see some nods there. So yes, I think this is really important that we do give this some serious thought, and I'm sure Charlotte will. I'm sure everyone will. Andrew, I can see you've got your hand up. Do you want to go first?
Yeah, very broadly similar to your point. I was just thinking we've had that really in-depth information about dementia and the kind of the universal things that as a community people could be helping and dealing with that would enable people to live longer and more healthy lives. And so it's that kind of bringing those two things together, because it will align with our health and wellbeing strategy, no doubt. And perhaps that's the conversation you and Charlotte have already been having. But where we've got JSNA information, where we've got strategies already in place, it's kind of trying to embed the community dimension of delivering those things. So that sort of focus in that 1 to 3 year programme, I would have said from a health and wellbeing board perspective, should reflect those things that we've been talking about today and have talked about in previous meetings. So sorry, that's a bit wordy, but hopefully I can just suddenly see a direct link between what we talked about just now and how the community could help us deliver that.
Yeah, exactly. I agree entirely. Charlotte, I think your hand is up next, and then Gronya. So thank you. Thank you.
Thank you. I guess there's two opportunities here for us. One, with the piece of work that's going to be undertaken, the co-design approach that we're going to take for the development of the new strategy, that Abby will absolutely have the community strategy as that desk-based baseline work that the provider needs to become briefed upon, and therefore the framing of the health and wellbeing strategy needs to complement that. So that's one part. But I was thinking also the structure and the ethos of the community strategy would also enable us to work with communities as a key partner in that co-design of the health and wellbeing strategy, and we need to think about how we do that. in as the strategy progresses, so that it's absolutely complementing and facilitating some of the actions and objectives that are identified under that separate strategy. So that was my just initial thoughts on the opportunities that might be present to us in terms of what we're doing with the board. And then secondly, the second question on organisational development and leadership, and some of those headlines that Marcus highlighted earlier around how we work together as a board and as a partnership. We'll wait and see what comes out of the discussion in November, but I think there will be some key recommendations and actions that come out of that around leadership, system leadership opportunities. And I wonder if there's something that we can look at aligning to the work of the communities and think about how we work together as a system, whether that's as a partnership health and wellbeing board or whether that's general collaboration and partnership working. So something that Abby and I will take offline and follow up on and continue to touch base upon. But I think there's absolutely going to be some opportunities around leadership development, system leadership, organisational development together collectively.
Fantastic, thank you. And Gronya?
Yeah, one moment, just checking I wasn't on mute. No, I really love us developing this strategy, as Abby knows. So not that I see it as a panacea for everything, but that just that real commitment to thinking about how our communities in Bracknell Forest are properly served across the board, because we've got some areas that in some pockets are really well developed. So at Crowthorne, they've got some really good services for people as they age, you know, well resourced, well supported. So people with dementia might almost get unnoticed because those supports sort of wrap around them as they actually go through that aging process and the dementia gets a little bit worse. Whereas got other areas where those services don't exist in that way. It's the same for people with learning disabilities in the community. You've got groups here, but not in other places. So for me, it's about whether you're a carer looking after a young person, a sibling, or young carer, whether you're somebody aging supporting an elderly carer with dementia or a partner with dementia. I think it's about how all of our populations are supported. I can see from the programme of work and activity, hopefully all of those communities and thoughts will have already been threaded into the development of the community strategy, and I'm hoping that it has. And I think through that, then how do we use those enablers within the community in the future to look at, you know, early intervention, prevention, without using those words. You know, how do we support our people to live well, you know, our populations to be informed, to have people who are champions and those sort of things in specific areas, and so that they know a little bit more and can share that. So I'm hoping that sort of thing is coming out of the work that's taking place. We deliberately didn't develop, in many areas they've developed prevention strategies. We deliberately didn't develop a prevention strategy for Bracknell Forest because we knew the community strategy was coming out, and we knew that with the health and wellbeing revised strategy and with the community strategy together, that should articulate how we're supporting people, you know, throughout their lives and throughout that lifespan. And I think we've also captured the young people in their families as well through that programme of work. So Abby, if there's anything that we still need to supplement that you don't think we've got enough of yet as part of that engagement process, then please let me know, so that we can you'll get more of an officer view as and when you need it, following the engagement with the communities, if there's any areas that are probably light or missing.
Thank you.
Brilliant, thank you. And then Phil.
Thank you, Chair. Yeah, I mean, what we've gone through really is quite a considerable undertaking, and we've got a huge amount of feedback, of insight, of messaging that's been gifted to us by the very people that we're all here to serve. So for me, the question is how we take that voice, that feedback into account to really inform our collective work going forward. Because for me, it's about getting the authorities right. We're all here to serve the people of Bracknell Forest, and the Bracknell Forest people have gifted us an awful lot of their insight and their view here. And it's how we take that as a collective and as individual organisations, and ensure that voice is really reflected now in all of our developments, whether it be our policies or our working practices into the future. Thank you.
Excellent. Abby, have you got anything to feedback on that?
Thank you. Yeah, appreciate the support from board members. As Phil has said, there's a weight of responsibility now on the delivery group to really ensure that we take on board all of the sort of huge amount of feedback that has come through over the summer. And thanks for Gronya's offer of support. If we do think there are any gaps, then we can certainly follow up in terms of having a further conversation. But in terms of prevention, the way in which the strategy will be aimed at supporting active, engaged communities will support that prevention piece that Gronya's talked about.
Brilliant, thank you. I mean, I'm glad you gave it a few extra minutes, but I am also aware of time. So thank you for that. And obviously we've got opportunities there to get in contact with you if we've got any further thoughts.
Thank you.
If we could just, thank you, thanks so much. If we could just move on to Mark Young, and hi Mark, and your presentation on the Frimley ICS Joint Capital Plan, which you'll have to help us understand, or some of us understand exactly what that means. So thank you, thanks.
Yeah, no worries, and hopefully you've got the plan. I'm not sure if it's if it needs to be shared, but you should have that in the pack. And to be honest, this is really hopefully kind of a side note. This is the amount of capital that Frimley ICB get each year, and I would suggest that if you kind of walk your way through to the end, really that's the summary. So the last slide shows the division of capital to primarily, we've only got one provider within the system, or NHS provider. The operational capital at 42.488 going to FHFT, and then Frimley ICB operational capital. That operational capital is spent under GPIT, so IT systems for primary care. And MIG is premises improvement. So yeah, so as I say, I'm happy to go into more detail, but really this was for noting more than anything else, that this is the allocation of capital for this financial year.
Thank you. I just had oh sorry, Sue, you go first. Thank you. All right, well, my question was just quickly, there's a contribution from the GP practices to is that right, 34%, and then 64% from you guys, but I also wondered about things like external fundraising, things like cancer centres, and when there's sort of private wings and things like that. How does that go into this capital plan?
Yeah, so this capital plan doesn't reflect the other thing this doesn't include. So this is almost kind of, I'll term it kind of BAU capital. So this is how much is allocated. So business as usual, allocated to the ICB on a kind of yearly basis. And this is the division. It doesn't include if either providers or the ICB are successful in kind of attracting central funding. So for example, the Bracknell Centre for Health, which you'll to be aware of, currently under construction, and that isn't included on this. So it doesn't include central funding, and it doesn't include, as you say, any kind of fundraising efforts. So those are slightly separate. But this is the capital given to the ICB, the Frimley ICB system, and how it's divided that resource. But yeah, it doesn't include any additional in terms of GP. So the 1.4 there, which is split out into GPIT, and then kind of day-to-day estate related premises improvement. When money is awarded to the GP, there is an expectation of that percentage contribution. So and there's for example a title exchange, so written into the title for a GP, a privately owned GP practice, for example, they will contribute a certain amount, and a certain amount will be awarded, and then there'll be a legal exchange. So there's a whole process around awarding that to primary care.
Sorry, brilliant. Thanks for that. Thanks for that answer. Sue, I see your hands up.
Thanks, Mark. Thanks, Councillor Wright. I had a question. You probably guess that someone's going to ask this question about neighbourhood health centres and the longer term plan. I think I heard somebody from the ministry said more clicks and less bricks. So you assume less investment, capital investment necessarily into the bricks and mortar. But I'm really mindful that this is an annual plan. So how do we transition this annual plan to something that's longer term, that is going to transition to that more sort of neighbourhood planning concept? And that I think that's one main question. And then looking at this annual plan as well, how do you measure your return on investment? Or do you sort of, what are your measures that you use against the capital funding that you allocate?
Or so Susan, I'm firstly just going to slightly caveat that so I'm slightly new to from the ICB. I've been there a couple of months now, coming from a provider in a different geography, but certainly to both points. So in terms of how do we how do we move towards a more neighbourhood-based healthcare system? So you will have seen, obviously, the new kind of 10-year plan and that left shift of activity towards the community. In terms of particularly, I can speak for the estate-related work that we're currently doing within the system and with providers, primary care, and colleagues across the patch. Is trying to understand, well, firstly, working from a where is the population need. So you've already mentioned here about things like JSNA, etc. You know, where is the genuine need of the population, and what does that mean for how you transpose services, for example, from acute into community to try to prevent the kind of higher acuity. This is particularly relevant for Frimley as a system with a new hospital programme kind of on the horizon. So we're heavily involved in some of that, and again, how you can provide services closer to the population centres and the areas of deprivation. So that should be the lead thing, really. In terms of the physical, what does that mean for what we're doing? Particularly, I've been asked to get involved in master planning of some of the sites. So some of the sites around the ICB, you know, what is the art of the possible? How much could we, how many services could we put on a particular site? You know, what are the constraints, and how do we work with local authorities to tie that together? You know, what should that model look like? I think the conversations will happen over the coming, or have certainly started to happen, and will happen as to, well, what does that mean for how that comes together? What services should be co-located, and what will that prevent in kind of upstream activity? Certainly from an estates perspective, we're trying to understand, I've termed it, how big could the box be on some of these population-centered sites, and then what will we, you know, what services are appropriate to have in there? So it's kind of that parallel thing, and particularly for estates, takes a long time to kind of gestate and get onto site, and so we're doing some of these things in parallel. It's certainly an exciting thing, and for me, again, prompted by that new hospital piece of work, you've almost kind of, you're building a burning platform and having to answer that, well, what needs to be true of the community in order to make the case work. To your second point, and it kind of segues into that, the process for kind of, as I say, the presentation talks about BAU capital, but the same thing for centrally attracted capital is firstly a robust business case. So for all of any kind of awarded capital requires a business case that says, look, we're going to spend it on X. This is the relative activity, or this is why, you know, this project should be prioritized, and then that kind of works into, and there's very prescriptive ways of doing that. So for example, Green Book methodology for how you prioritize based on population need and benefit, etc. And then how we prove that we delivered what we said we were going to do is through a process of post-project evaluation. So again, all kind of fairly standard kind of tools, but really trying to make sure that we maximize the investment. That with respect, there's not a great deal of, you know, what you can get bricks and mortar wise for the money these days is not that great. So we're trying to kind of have the strategy, and then have the steps, and then attract the funding in order to make, you know, for best effect, essentially. hopefully
Thanks,
that
Mark.
starts to answer you.
That's great. Yeah. How do you avoid building something that's not going to be used, and how do you measure the success of it, and how? Yeah. It's a really tough one. Okay, brilliant. Are there any more questions for Mark? No, everyone okay? All right. Thank you so much, Mark. That was really interesting, and really interesting to hear your answers. Fantastic. Thank you. Just look at the agenda. I think the next item is actually meant to be Nicola, and she's not with us. There's no one here to present on her behalf, is there? This was the ICB restructure update. I don't think there is. So should we just defer that to next meeting? Okay. All right. Maybe then it might even be a bit more stable and should be able to give us a good update of what actually is happening. Okay, fantastic. Do we have any other agency? Okay, thank you, Gronya. Thank you so much. Do we have any other updates from any other agencies? So we've got, I've lost you. Sorry, there you are up there. We've got Health Watch with us. We've got Involve. Fidelma, I don't know if you want to give us an update. If there's anyone who'd like to give any updates from their agencies, it'd be interesting to hear. And then also if there's any other business. Claire, do you have an update for us?
I was just about to say, I'm looking for the hands up button and I cannot find it, and I always do this on Zoom. So I was just about to wave at you.
Okay.
Yeah, thank you. Just to say, we published our Women's Health report last month. I was at the place meeting yesterday, so this is a repetition for some of you. I apologise. It's on the Bracknell Forest Health Watch website and our other East Berkshire websites as well, and will likely have been circulated to you via email. Please do have a read. If you have any questions or queries, or light bulb moments in terms of actions that can be taken off the back of the findings and the recommendations, please do shout. We'll be following up with Frimley in December just to have a chat and see what progress they've made against the recommendations there. And we've got a piece of follow-up work that we're doing with the DALS interpreter service around some resources that it might be helpful to pull together for some of those kind of gaps that were identified. And we've also recently conducted an interim view visit at Pinehurst Care Centre. That report should be out at some point next month. So that's all from us. Thank you.
Thank you. Anyone else got any updates for us? Phil? Yeah, can you not find your hand? I think it's in that
my hand too. I couldn't find it in the selection there. Well, just to make colleagues aware that we now have a full complement of community development workers for our Thriving Communities initiative, which of course we're working with the local authority and partners on delivering, looking really at that co-production piece within our communities and strength-based working, which aligns with our community strategy, of course, which Abby was introducing earlier. So just to say, we've gone into year 2 now and have identified through needs-led data the areas in which we will focus our energies. So in addition to the pilot area of the town centre, which many of you will remember in year 1, we're also starting to form pathways and relationships within East Amsterdam Wild Ridings and Priestwood and Garth. So they're our year 2 and possibly 3 areas, which will complement the work that we're actively doing within the town centre. So that's really encouraging, and I think it will serve us well for some of the broader ambitions we've got in terms of how we work with communities into the future. Thank you, Chair.
Brilliant. I love the Thriving Communities projects. Okay, and then Jonathan, have you got any updates for us for the Health and Wellbeing Board?
Thank you. Sorry, I was struggling to find the hand as well, like everybody else. Gron, you may want to come in on this, but I think the probably one of the most important things to mention, a number of people will know that the annual report for 24-25 is in the process of finalisation. It's due to be signed off by the LSPs on their meeting on the 18th. And so maybe scheduling that for a future meeting of the Health and Wellbeing Board. I know last year's became a little bit kind of out of sync and was quite late coming, so maybe getting it to the Health and Wellbeing Board at an earlier point, and I'm sure probably Grania would be well placed to talk to that, but happy to support that if that makes sense.
Thank you. And that's the Bracknell Forest Safeguarding Partnership Board report, annual report, isn't it? Okay, thank you. No, that's good to hear. Fidelma, have you got any updates for us or any observations? Oh, maybe she's not with us just now. And then Sita, have you got any updates or observations for us? She's in your room, isn't she?
I'm coming in so we don't have the echo issue. Nothing for the board from a public health perspective. We'll bring any relevant papers back.
All right, well, thank you so much, guys. Nice to give you all an extra 28 minutes, and thank you so much. And the date for the next meeting, I think, is the 26th of November. I will double check, sorry, unless Lizzie's there to excuse me 1 second.
It's the 27th of November.
27th. Oh, sorry. Yeah. So next, so we've got the health and wellbeing workshop on the 24th of November. So that's on the Monday. Let me just double check. Yeah. And then we've actually got our health and wellbeing board meeting on the Thursday, and I'll be joining you from Bournemouth, I think, because I'm at the local government, the Adult and Social Care Conference, but I'll be joining you from there. But that'd be fantastic. Okay. All right. Anything else before we say goodbye? No. Okay. Thank you very much, guys, and see you in November.